All right. Hi everyone. Thanks for having me here. I'm pretty excited to be here. You guys are doing some great things with this response center. Um, so I know it's probably been a really long day for you all. It's already 4 o'clock out there. I'm on Central Time. So hopefully I won't keep you too long, but hopefully we can have some cool discussion. I know I'm speaking to a bunch of experts in the field, so I'm a little nervous. I'm pretty new in the field, so I've only been doing this for a couple of years. I'm grandfathering from toxicology, so hopefully I won't bore you with too much stuff that you already know. Um, Never met Dr. Manini before. Exciting to meet you. Read all your cool tox papers that are coming out and send the tox world for a whirl. Um, so let's see. Okay. I just found some historical stuff. I kind of found this cool little fact back in the fall when I was just reading up on opioids one day. Apparently, some of the first recorded experiences with opioids date back to like the ancient Sumerians. They were sort of like the first civilization known to describe the opium poppies as sort of like a joy plant, and this is in circa 3400 BC. And they were referring to like the euphoric effects of the plant. And they soon sort of passed on the poppy culling knowledge and its knowledge and their knowledge of its euphoric effects, analgesic effects down to the Syrians who passed it on to the Babylonians, the Egyptians, etc. And if you look at history, we've definitely had different eras of opioid epidemics. We know that morphine was eventually purified from poppy seeds around the time of the US Civil War, and this coincided with like the invention of the hypodermic needle. And so morphine was used heavily during the Civil War, and then mass addiction was sort of spawned during that time. And the syndrome was dubbed as soldier's disease. So I thought that was kind of interesting. So maybe one of the first opioid epidemics in the US.
Okay.
Sorry.
Guess we'll get started.
Sorry, I think it's like your audio was on, but it just turned off. So thank you.
Oh, is it me? Sorry.
Nope, you're good, Dr. Atti.
Oh, okay. I thought someone wanted to say something. Okay. So I'm going to do the most cliche thing ever and talk to you guys about my kid. So I'm a new parent. So these are some unsolicited pictures of my baby. So he's my little miracle baby. He just turned 1 a couple weeks ago. So as seen here, he's also a budding toxicologist, and he loves the very hungry caterpillar. That's him enjoying his birthday cake, his hungry caterpillar themed birthday cake. He's not a very good hungry caterpillar himself, however. He doesn't eat very well. He throws most of his food on the ground, except for if he's at daycare, if he's around other kids eating. And I was speaking to like a developmental specialist at the daycare, and they were saying that there's peer pressure at daycare, and that's why the kids eat so much there. And I was just blown away by this because, this kid's only 1 year old and he's already influenced by peer pressure. And I didn't think it started this early, but it does. And, it's been a really crazy year, been very stressful. I have so much empathy for working parents now. But, everyone keeps saying it gets better. And, but then I keep thinking, like, really does it? Because I'll soon have this broody, angsty teenager on my hands who finds me annoying. And pretty soon during that time, I'll have like real stakes to deal with in terms of peer pressure. There'll be like, more risky things that he'll probably be engaging in that will be involved with peer pressure. And so I really am thinking to myself, does it really ever get better? So pretty soon my kid's gonna have, he'll be in adolescence. It's a developmental period that's characterized by suboptimal decisions, actions, and that adolescent brain is primed for risk-taking behavior. And adolescents have a lot facing them today. So how do we even navigate this as parents or physicians? And I'm really dreading that inevitable encounter and opportunity to experiment with substances that will arise as an adolescent and the peer pressure that's associated. And we know the data. We know that kids who experiment with substances are more likely to develop substance use disorders as adults. So we're here today to talk about opioid misuse. So what is opioid misuse? It's the use of prescription opioids in any way that a doctor did not intend for you to use them or direct for you to use them. It usually involves taking prescription opioids in amounts more than indicated, or using with alcohol, or using with other substances to get high. It might involve injecting them or insufflating them. What's concerning is that the CDC does report that prescription opiate misuse is starting to be on the rise again. We all know that part of how we got here today with the opioid crisis is characterized by over-prescribing of opioids. And that, of course, peaked in the early 2000s. It's since been on the decline, but coinciding with COVID, according to a recent CDC survey, a youth risk behavior survey, which is a cross-sectional high school-based survey, they are saying that 14% of high school students report misusing prescription opioids. And there's also SAMHSA data indicating the same, where approximately 670 adolescents initiated opioid prescription misuse, according to SAMHSA in 2019, and that was daily. So what's concerning is that the stakes are pretty much higher now than they were like in the early 2000s. And we know that because, opioid overdoses are more deadly more likely to result in death. There is illicitly manufactured fentanyl in street opioids. So the stakes are much higher with opioid misuse on the rise. So adolescents are obviously, initially maybe initiating misuse at home with prescription opioids, and then eventually moving to illicit sources or other sources of diversion, including street traffickers or street drug traffickers. And those prescription opioid pills that they might be looking for typically will have fentanyl in them. So according to CDC's state unintentional drug overdose reporting system, which characterizes and trends overdose deaths for adolescents, they found that in 2019 to 2021, 84% of the opiate overdoses involved illicitly manufactured fentanyl. Of these decedents, only 35% of them actually really had documented opioid use disorders. So that's, not surprising because, again, fentanyl is typically an additive to other drugs available on the street. Typically these kids are not going out there seeking fentanyl. They might be seeking Xanax or oxycodone, and, these counterfeit pills will typically contain fentanyl, which all of you are very aware of. And a lot of these counterfeit pills will have, cartoonish designs. There's like this Trump ecstasy pill that was like going around a few years ago. And then there's this picture from the DEA website that was warning of brightly colored counterfeit pills that contain fentanyl, but they're, basically designed to target young people and drive addiction amongst adolescents. So this is a Jack. So sort of like a random story, but like kind of framing, the three legs of discussion that I want to bring up with you guys. But this was like a news story from British Columbia, Canada. I'm from near Vancouver, Canada. That's where I was born and raised. I was a resident when the story kind of came out. It was sort of like around the start of the third wave of the opioid crisis. There was sort of, a rise of deaths from opioid synthetics that had started, and illicitly manufactured fentanyl had started sneaking into the drug supply. But this was like a story of prescription opioid misuse that had gone awry. So this teenager, Jack, thought he was ingesting oxycodone that he had obtained from the street, but it ended up being fentanyl, and he overdosed and died. And his family was like on the news saying, we thought he was just experimenting. We thought this just was a phase. We didn't think much of it when we found out that he was, seeking out prescription or misusing prescription opioids. And I was a resident at the time, and I remember just thinking like, wow, this kid was like seeking out oxycodone, and that's not really like in my mind an experiential drug. Like it's so dangerous and addictive. But it's just like an example of how like the stakes are so high in terms of misusing opioids these days. This is obviously like more than kids just behaving badly or just occasionally it might start with wanting to experiment, try new things, but this really can lead to severe addiction, and underlying that is like the neurobiology of addiction, which I'm going to go over, is really interesting in terms of how the adolescent brain works and what makes them susceptible. So I really think how we're tackling the opioid crisis is we're missing like a big piece of the puzzle. That's how I feel really strongly about that. I feel like adolescent medicine is not being targeted enough or involved enough in the opioid crisis. The AAP, or the American Academy of Pediatrics, has called on pediatricians to start screening adolescents and young adults for substance use and start managing the entire spectrum of substance use disorders at that age, from pre-initiation to like, full on, opioid use disorder or other substance use disorders, and integrating substance use treatment amongst that within that whole spectrum within their primary care practice. And I think it's I don't know, I think we're really behind in terms of prevention. We're just kind of we're very much like mitigating like this disaster from like the back end. And so I think there's like a lot of opportunity here. And I just learned a lot getting ready for this talk, and I hope that we can convince more people to focus more on adolescent medicine prevention. There's basically like 3 pillars to this talk. I just wanted to briefly review like the neurobiology or pathophysiology behind the adolescent brain, because this, if you look at adults that are struggling with addiction, most of them really did start using when they were adolescents, when they were young, when they're 13, 14, 15, and now they're in their 40s and 50s trying to, enter recovery. So and it really has to do with like, that experience they had as a young person with a drug that led them to this lifelong illness. Like most diseases, there's risk factors. So what are the risk factors associated with these adolescents who are going to, misuse opioid prescriptions? And, what risk factors do we look for? And what are sort of like the screening and prevention tools out there? So this slide might give you PTSD from medical school. Obviously, the brain is very complicated, but for this presentation, I'm going to keep it really simple, mostly for my own benefit. But the mesolimbic circuit is involved in control of mood, behavioral learning, stimulus response, habit formation. The most commonly implicated neurotransmitter is dopamine. There are some key regions. There's the ventral tegmental area in the brainstem. There's a dorsal striatum, nucleus accumbens, the hippocampus, amygdala, and prefrontal cortex. And they all have their relative functions that are involved within the reward circuit. What makes adolescents really vulnerable to addiction within the mesolimbic system is that the prefrontal cortex, the part of the brain that's involved in executive functions that supports careful decision making, like self-monitoring, impulse control, doesn't develop fully until they're in their mid-20s. And some literature says it doesn't fully develop in some people until like their 30s. So they're basically less deterred by risk. Like they're not as scared of risk or the bad consequences of the risk they might be taking. And then the emotional processing, reward-seeking centers of the limbic system mature much quicker. That's mostly the nucleus accumbens that I'm talking about. So relative to kids and adults, adolescents have this exaggerated nucleus accumbens response in anticipation of reward. And they also have more dopamine receptors. So there's sort of this uneven maturation that results in susceptibility for engaging in really risky and impulsive behaviors, and that includes substance use. And it also increases their vulnerability to reinforcing rewarding effects of the substances. So, an adolescent uses a substance, there's like this exaggerated positive response, and then the prefrontal cortex gets a message like, hey, that was really good, we need more of that. And then they get these sort of lasting memories that are created of the experience in the brain, and there's good feelings associated with that experience and the circumstance and the environment in which they occur, and these become like conditioned associations. It might drive them to like seek out more drugs. And this phenomenon peaks during adolescence. And it's at the time where like they have less meaningful reward results from like, smaller rewards that might excite like a child. Like a kid might get excited by like a sticker or something for being, having good behavior all week. They're actually developmentally wired to pursue much more highly stimulating behaviors to garner a larger neurological reward. And that's why they are more willing to take very big risks, like drive crazy, try drugs. They might might have more risky sexual behavior, etc. So anyway, it's a developmental drive essentially. So preventing or delaying substance use or opioid misuse among youths can really reduce their later risk for substance use disorder development. We also know that trauma really affects the maturation of the limbic system. So changes in the neuroplasticity, making them more susceptible to risk-taking behavior and addiction. So kids that have like a bad childhood or adverse or traumatic events are more likely to go on to use substance use disorders and also have more profound rewards from it. So it makes them really more susceptible to neuroadaptation on the neural circuit level, where the brain, when the brain's rewiring little by little with each use, they're having more profound effects from substance use. And more and more use obviously leads to development of tolerance, and where they need escalating doses to achieve that same effect they first had. And we know opioids in particular really completely hijack the reward circuit and create really intense symptoms of euphoria. And many of those who develop OUD are chasing that first high, which you all know. And another consequence of this adaptation is like a decreased sense of satisfaction or reward from other naturally rewarding stimuli, like hanging out with friends or eating good food. So the amount of dopamine release is just not the same, and so there's sort of like a new set point that's developed, and that's what they and these changes are much more profound again in the adolescent brain. And you can conceptualize some of the factors that are driving this continued use through 3 stages: intoxication, withdrawal, craving. And there's essentially disruption of the brain regions that are responsible for motivation, reward, inhibitory control that makes it really hard for them to break out of the cycle. So where are the opioid receptors in all this? I mean, again, I'm preaching to the choir, you guys know all this, but the 2 most important receptors, the mu receptors and the kappa receptors. The mu receptors activate like the reward pathway, and cause through interneuron projections will interact with dopaminergic neurons and cause disinhibition of dopaminergic cell firing, and are mostly responsible for the euphoric effects. And the kappa opioid receptors are activated mostly through, or they're mostly involved in sort of that depression and hedonia stage, where they're kind of activating like the abstinence withdrawal stage, and might even be activated by stress, etc., leading to recurrence of use. So to summarize again, we know that the pathophysiology of the adolescent brain makes them very susceptible to opioid misuse and later development of opioid use disorder. So what are the risk factors? So we know this is a brain disease, and we need to understand the risk factors. We should have like a comprehensive risk profile of risk profile of youth who are likely to misuse prescription opioids. And this is especially important if you're a pediatrician or even working in the ambulatory setting in the ER, and you see a lot of these kids present to the ER and stuff. So I think there's really opportunity there to like screen within the ER and catch these kids in places like that, and refer them to the right places. But there are risk factors that they'll show up with it you can look for. Of course, there's like we're going to start with intrinsic factors. One of the things that is common, prevalent in CDC data, is that younger and other larger cohort studies, opioid misuse is really common in younger female adolescents, but as adolescents age, it becomes more and more common amongst male adolescents. So at higher grade levels or at age like 16 and above, it's mostly males that have opioid misuse. There is increased risk amongst sexual minority youths. They have significantly higher prevalence of current prescription opioid misuse, even after controlling for other demographic factors. It's not surprising that age at first use is inversely correlated with lifetime incidence of developing opioid use disorder. So if you start, misusing opioids at a young age, you're going to have a higher likelihood of having prevalence of prescription opioid misuse throughout your life. And the longer you prevent use in adolescence, the less likely you are to develop that. And that's the same for dependence. So another intrinsic factor is motivation. So motivation is a really interesting concept. The adolescent brain is really, really driven by the adolescent brain is very motivated by a strong reward response. And in this study by McCabe et al., they looked at adolescents who screened positive on the CRAFT questionnaire, which is like a validated substance use brief screening test for adolescents. Those who screened positive described their motivations as like experimentation or recreational use, and those that screened negative actually were looking for pain relief, and that's why they were misusing the opioids. So, but there are also many adolescents in in this study, 48%. I think this study had like 15,000 kids or something. 50% of them, when they screened positive on the CRAFT screen, were saying that they were using it for pain relief as well. So how many of you were like warned that, smoking a joint here and there is going to make you abuse other drugs? Well, that's like the gateway hypothesis or whatever. Like there's like gateway drugs. Well, the gateway theory has problems in that it tries to designate like one drug as being like the gateway drug to developing other issues with drug abuse. But what's probably better is like a common liability model that better explains the relationship. So there's tons of data just to suggest that early prescription opioid misuse increases risk for use of other drugs in general. Like in general, if you're going to use any drug, even if it's marijuana, even if it's just alcohol, you're probably more likely to try other drugs in general. So there's really not one drug that's, to blame. So another intrinsic factor to really think about is concurrent substance use when you're looking for risk factors. Like, are they using any other substance? It doesn't have to be like marijuana. In particular, what's concerning actually is binge drinking and alcohol use. So a CDC study actually looked at this and found that, adolescents that reported opioid misuse in the US actually were more likely to do so if they were having episodes of binge drinking, almost twice as much more likely to misuse prescription opioids than non-drinkers. And as the prevalence of binge drinking episodes increased, so if you had like 10 or more, your prevalence of opioid misuse increased greater than like 7 or 8%. So concurrent substance use is also found within twin studies. So drug escalation odds do increase. This one study found that drug escalation odds increased amongst co-twins who use cannabis versus not. So again, just talking about that common liability model. If you're going to use one substance, you're probably going to use others. So it's a good way to screen adolescents for opioid misuse. There's also genetic vulnerability. So opioids actually have a very large genetic component in, tendencies to use or misuse. Like obviously, if you have CYP polymorphisms that, where you get more you don't get as many adverse effects from the substance use and more beneficial effects, you're going to more likely have tendency to use it for longer than other people. Mental health, not surprisingly, is a intrinsic risk factor that puts adolescents at risk for substance use or opioid misuse. And during the COVID pandemic, adolescent mental health was declared a national emergency in 2021 by multiple professional organizations. And, coinciding with this is that opioid prescription misuse is on the rise, including overdose deaths amongst adolescents. It's probably related to declining mental health. So just summarizing, some intrinsic risk factors that studies have examined that are prevalent amongst risk profiles of adolescents who misuse prescription opioid drugs. So now looking at the extrinsic factors, hopefully we can do more about these. You can't do much about someone's genetics, but hopefully you can help, with some of this extrinsic stuff. So it's no surprise that if you have a bad childhood, you probably have a higher risk of developing misuse of opioids. So adolescents exposed to adverse childhood events are particularly more vulnerable, again, because there's that impaired emotional, social, cognitive development that occurs when you're exposed to multiple, especially if you have multiple traumatic experiences. And this decreases your ability to cope with stressful emotional stimuli and also changes some of your neuroadaptation and increases your risk for substance initiation and development of substance use disorders. So the CDC study actually looked at adverse childhood experiences in relation to recent opioid misuse, and the odds of opioid misuse increased as the number of adverse childhood events increased. So kids that were experiencing 5 or more adverse childhood events were 15 times more likely to report opioid misuse than experiencing no adverse childhood experiences. So friends obviously really matter. If this is like a top diversion source for adolescents, friends will offer you, prescription opioids they might have at home to try, or get them for you. There's also this concept of cultural acceptability. Adolescents are really susceptible to like what's acceptable in society. Like right now, opioids are bad. Like fentanyl is bad. Opiates are not like as in vogue as they were maybe like the 90s, early 2000s. So there's definitely been like this change in cultural acceptability that's kind of brought opioid prescription misuse down considerably than what it was back then. But again, like the consequences of using them are much higher now. Um, and this is also why, so many like, alcohol ads, etc., are targeted at young kids, like they make, if you have like a beer ad with the young, attractive people hanging out, that's like showing cultural acceptability, it's very influential to them. So another extrinsic risk factor is family. Families are another top source of diversion or prescription opioids. So a third of adolescents report obtaining their prescription opioids from family members. And this is like, again, related to that sort of like cultural messaging or modeling by families, um, even just like, oh, like what's acceptable in the home, like, if you have a headache or something, there might be like friendly sharing, like, oh, it's fine. You can use like, oxycodone for your headache, or your shoulder hurts. Here's like a oxycodone pill I had, or here's Perks that I had. So that sort of like can trigger, opioid misuse. There might be other active substance use going on in homes. There might be limited parental monitoring, or there might be, parents aren't getting rid of pills they might have been prescribed and kids get into them, etc. So again, families are like a big extrinsic risk factor. So this is just a study that was done by McCabe et al., where they looked at family opioid misuse related to family members' prescriptions. So as prescriptions go down throughout the years, especially around like 2000, around 2010, prescription misuse went down. So this is again very much related to your family, your environment. So social determinants of health they pretty much confound a lot of healthcare, and they especially confound substance use disorders, or also your risk to misuse opioids. So in particular, adolescents from low income households, poor access to healthcare, or from homes where there is housing insecurity, unemployment, they're at highest risk for opioid misuse. So to sort of bring this all together, there are intrinsic and extrinsic risk factors that you can look for that can help you screen for adolescents. So moving on to like the last leg of this, screening and prevention, in the sea of like very impulsive teens, how do we truly find these kids? It's not always that obvious of a problem. There are obviously risk factors you can look for, but like, how do you find that kid, Jack? Like how could we have found him and prevented him losing his life? So, actually, what you can look for is high risk behaviors. There's actually a whole CDC study on this, where they looked at around 15,000 kids. The youth with a history of prescription opioid misuse may be at higher risk for a broad range of other risky behaviors that contribute to their overall morbidity. So in this youth behavior risk surveillance survey, where they looked at kids that had opioid misuse, they looked at other risky behaviors that they were taking part in. And these, there's close to 15,000 kids that they looked at. And they found that, risky sexual behavior, risky driving behavior, risky violent behavior, like carrying a weapon such as a gun, or suicide attempts, or other high risk substance use was reported more often than not in all of these kids that were misusing opioids. So what does this mean? This was like a cross-sectional study. Obviously, that has some limitations, but the study does provide a snapshot of what risky behaviors are associated with prescription misuse that you can look for in the ER, or some sort of other ambulatory setting, or in a primary care setting. I mean, how many kids show up to the ER looking for STD screening or a pregnancy test, or they got in a bad car accident because they were intoxicated, or there's been sort of like altercation that they got into and they're there for evaluation, for like a blow to the eye or something. So those are good kids to sort of like screen other opioid misuse. Where can the screening be done? Obviously, this can be done. It's recommended that primary care physicians do this. But if you look at data, kids are more likely to divulge this sort of information, misusing opioid prescriptions, etc., in like a ambulatory setting, so like an ER or an urgent care. I found that interesting but it makes sense. Like, it's probably harder to tell your pediatrician or your primary care doctor, having that sense of like they might tell my parents, or my privacy might get violated. So it's probably easier to tell an ER doc that you don't know very well that you've been misusing opioids. And so how would you do that? Well, actually, what's recommended by the AAP is the screening, brief intervention, and referral to treatment survey or method. It's a essentially like a screening tool that has that's validated, and it's short, it's brief, and works really well. So I'll talk a little bit. Talk a little bit more about that in a second. But there is a tool there that can be used. So what's concerning, actually, before we move on to expert, is that it turns out that physicians are not that good at improv. So less than half of pediatricians who see youth use validated screening questionnaires to sort of screen for any sort of substance use. They usually rely on their impressions, and it turns out that has really poor sensitivity. So this probably wouldn't be acceptable for any other disease. Like, you wouldn't like look at someone and be like, yeah, like you have a high risk for stroke, and I'm just going to make a guess, and you don't. It wouldn't work that way. Or you have a high risk for diabetes, and you probably don't. And you wouldn't just leave it that. You would initiate screening. But that's what is done commonly for adolescent substance use, and this obviously has very poor sensitivity, or and doesn't work very well. So moving on to the screening questionnaires that I kind of touched on earlier, CRAFT is a validated, developmentally appropriate, brief, easy to use screen. Has really good discriminative properties for determining high risk substance use disorders in the adolescent age group. There's nothing like super specific for opioids, but CRAFT in general is a tool that's used. It's really brief, takes less than 2 minutes. And has pretty good sensitivity. It's like 92% sensitivity and 82% specificity in helping figure out who needs treatment. Recently, CRAFT was introduced into the expert screening method and published as part of a policy statement by the AAP. So this is like an adolescent expert algorithm that kind of incorporates it to and gives like a suggested way in how to screen adolescents. And looking at this, it looks very like convoluted and like what's even going on there. Well, I made it a little bit easier here. So you can ask some screening questions for any substance use. They give some examples here. And then if there's a positive CRAFT score, so that'd be anything greater than 1. If it's like less than 2, you give them some brief advice. And there's examples within the AAP policy document or policy statement. Anything greater than 2, you start, screening for risk of addiction, and moving up that scale, signs to having, signs of a very acute risk of acute danger. There's different interventions that are recommended, and suggestions for referral to treatment. How do you converse in these interactions? Especially in the ER, like you're really busy, like how would you, it's really hard to like kind of pause and do this kind of stuff, but you can. This doesn't take like a lot of time. It can take like I said, like a couple of minutes, but you really want to converse in a way to minimize resistance. As you all know, like part of the disease is to have resistance to this sort of conversation, and telling adolescents who are pretty invested in like their opioid misuse to stop using can really trigger more resistance. So, using something, presenting confidentiality and doing like small negotiating interviews or motivational interviews, helps them see their problem on their own. You guys are probably looking into motivational interviewing. I think it's something that we don't do enough of in all of medicine. Like, there's a lot of behavioral changes that are needed in getting patients to change their behaviors. It's not just substance use. I don't think we're very good at this in general, and we can use a lot of work as physicians. But an example would be like something brief would be like, like an adolescent is telling you about how, yeah, they are using a lot of alcohol on Friday nights, and then this is affecting their performance in their basketball tournament on the weekends, and that's affecting them in that, they might not get that basketball scholarship they wanted for college or whatever. And you would just like reiterate that and be like, so, you're telling me this, and so what are your, so you're telling me this is going to be bad for your college applications. You have these hopes to play college basketball. So what are your plans to like plans about alcohol in the future? And, trying to get them to kind of think about this and motivate themselves. So another thing that we really need to work on is destigmatizing specialized treatment for adolescents. There's like a lot of a lot of adolescent providers and pediatricians are scared, or no, I shouldn't say scared, maybe unfamiliar with MOUD, medications for opioid use disorder, or other medications for substance use disorder. They might not be very familiar with this stuff, or there's like stigma around it, and parents are not very understanding. So when you go to refer people to treatment, you really should know what's available to the patient, and addressing like underlying trauma, et cetera, is really important. Trying to destigmatize this for the patient and the family. And it's a really good idea if you're going to be screening people in your ER or whatever, knowing what's available in your area for an adolescent, having good, effective working relationships with these places, referral places, and having case management and social work on board to help you, and maybe even peer support. So there's other tools to screen adolescents. Again, there's not really like anything specific for opioids. There's like a lot of alcohol screening questionnaires out there, but CRAFT seems to be like the most validated and using sort of like an expert method. So, um, the other thing I think we can really start incorporating is improved trauma-informed medical care. I think it's definitely the future of medicine. It's a CDC priority area. We can't prevent childhood adverse effect events always. Like things just happen sometimes, and we can't always prevent that. So what we need to do is probably translate or improve our understanding and translate like the neuroscience of how trauma is processed in the brain, and incorporate that into all aspects of healthcare delivery. Like it's really hard to get an adolescent to stop opioid misuse if there's underlying trauma that's not being addressed. So even thinking about like a COPD or like keep smoking, you keep telling the COPD stop smoking, but then obviously they're getting something from that nicotine that they're not getting from anywhere else, and they're obviously coping with something. There's probably some severe anxiety or something that the nicotine's helping quell, and that smoking, or there's like some social thing around there that they're not getting from anywhere else. So it's hard to get them to stop that behavior that's progressing this severe disease without addressing that underlying thing. And hopefully we can get there one day in medicine. When dealing with adolescents that are struggling with opioid misuse, it's really good to look at some protective factors that you can incorporate into your care referral systems, and that's to engage strong parental support, helping parents improve their attachment with children. I mean, we're not going to do this in the ER, but this is like one of the things that could be emphasized in caring for these adolescents, is like maybe even breaking confidentiality and getting strong parental support, getting helping quell their myths and stigmas they might have against whatever the child is dealing with. So there are like educational tools out there. You could print some of these or have some of these in like your discharge instructions. There's like a really good NIDA website out there with good science behind drug abuse that's intended for teens to read, etc. And we could probably print more of this kind of stuff for adolescents in peds emergency rooms or general emergency rooms. We probably need to also work on our residency training, and we have like no problem running a simulation with like a code or like a serious, calcium channel blocker overdose or something. We have no problem running simulations for stuff like that. But when it comes to like, expert education or, motivational interviewing, that sort of thing, or anything to do with addiction medicine, we're like pretty hesitant to do anything like that. We consider it soft. etc. So we don't have very good curriculum, I think, in our training programs. We could also be more extreme. I think there should be I think there has to be like a call to action in improving adolescent addiction care. We have no problem starting diabetes screening and calling people pre-diabetics, and then we continue ongoing surveillance for them to make sure they don't develop diabetes, or if they do, we catch it. We do that with like some cancer screenings, right? Like there's cancer risk factors we look for. We do surveillance. So we should probably start doing this for adolescents, and maybe we need to be really extreme and open like surveillance clinics. Like, oh, you're at high risk for developing opioid use disorder, so we're gonna keep you in this clinic. You're gonna come, quarterly. We're gonna talk, see how you're doing, make sure you haven't developed addiction. So maybe we need to get like very, very extreme in how we deal with this problem. Have you guys ever watched Beautiful Boy or read the book? I think it's like I don't know. I remember it was like one of the first visceral reactions I had to like a addiction stuff. That was like a few years ago, and turned my interest on for this. And I don't know, what I found was really great about this book is that there's hope. It can be treatable. These people are not like a lost cause, even if